Hello, I'm Dr. Farzan Bahin from the Department of Gastroenterology and Hepatology at Westmead Hospital in Sydney, Australia, and I'm delighted to present our paper published in Endoscopy entitled Prophylactic Clip Strategy is Cost Ineffective for the Prevention of Clinically Significant Bleeding following wide-field endoscopic mucosal resection of large sessile and laterally spreading colorectal lesions, an economic modelling study. And my co-authors are Dr. Rasouli, Williams, Lee, and our senior author is Professor Michael Burke. Wide-field endoscopic mucosal resection of large laterally spreading lesions is now a standard of care and has predominantly replaced surgery as the first-line modality. The key problem with EMR in the colon is bleeding, which entails with it morbidity and rarely mortality burden. In addition, there's significant economic impacts from having to treat clinically significant bleeding. Prophylaxis is desired, but at present promise is held with clipping of the EMR defect for EMR bleeding prophylaxis. This has not been backed, however, with high quality evidence, and there are several challenges with completely closing a defect that is of large or unusual size and shape with clips. Any prophylactic clipping strategy should be rigorously evaluated with an economic analysis to see whether this is feasible from a health payer perspective, and this was the aim of our study. We used the Australian Colonic Endoscopic Mucosal Resection database, the ACE study, to evaluate the outcomes of this study in regards to clinically significant bleeding, and applied a hypothetical economic model of either 100% or 75% efficacious prophylactic clipping strategy, and compared the costs of clipping versus not clipping. We also looked at selectively clipping in the proximal colon versus distal colon, because in the proximal colon the bleeding rates are higher, about 2 to 3 fold, and therefore it may be more viable economically to do that. We define clinically significant bleeding as any bleeding following the completion of the endoscopic mucosal resection requiring emergency department presentation, hospitalization, or an intervention such as colonoscopy, hemostasis, angioembolization, or surgery. We use several markers to evaluate economic viability, the key one being the expected cost of treating a clinically significant bleed, as well as the funds needed to spend to prevent one significant bleed. We also looked at cost neutrality analyses, where a sensitivity of how low the clip price would need to be was looked at to make EMR clipping neutral, cost neutral. The key findings of the results are shown in the figures and tables referred to in the paper. But the key findings are that we had 1,700 patients evaluated. The mean size of the lesions was 35.8 millimeters, and just over half of the lesions were in the proximal colon. The overall rate of bleeding was 6.4%, 9% versus 3.7% proximal and distal respectively. Endoscopic management was required in 45% of bleeding cases. When looked at a clip distance of 3 millimeters between clips, which was the main reference for us in terms of secure closure, the expected cost of prophylactic clipping was 1,100 euros per lesion, compared to 157 euros if not clipped. And at 100% clipping efficacy, the funds needed to spend were just below 15,000 euros, and that was 30,000 euros for a distal lesion and just over 9,000 euros for a proximal lesion. The price of clips would needed to have come down to 10 euros per clip rather than the 80 euros that it's at market value at present to derive cost neutrality. So this results reflected over various other clip distances are quite similar. Of course, the cost and the funding needed to spend goes down if a clip distance of, for example, 10 millimeters is applied, but in clinical practice that is unlikely to derive significant prophylaxis. Even when a cost of bleeding was applied to look at the overall value of clipping, and the cost we used was over 4,000 euros. The prophylactic clipping strategy still did not offset a no clipping strategy model. So in summary, at present, a prophylactic clipping strategy is not cost effective and at present can't be justified routinely or even selectively in the proximal colon. Certainly prospective studies are required to confirm this finding, but at present it would be difficult to justify this from a health payer and economic perspective. Thank you very much.